under the stress, they acquire this plasmid. But if we remove the stress of that particular part, eventually they lose the plasmid. These organisms, specifically gram-negative, pose a big burden. Burn. If you see these kind of patient, burn immunocompromised patients or a neutropenic patient, Pseudomonas we have to keep in our mind. As per the WHO definition of antimicrobial resistance is microorganisms that are not inhibited by achievable systemic concentration of the antimicrobial agent. So what does it mean?
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
And good evening, everyone. So yes, as we know, today's AMR week is starting, and as we know, the topic of today is cracking the code for antimicrobial resistance. As we know, this year's theme about AMR is we should act now, protect the present so that we can secure our futures. So definitely negative resistance. Why I choose today's topic as a gram negative? Because as we see, gram negative organism, as we know, most of us, we are working in ICU settings or in oncology or in a transplant setting. These organisms, specifically gram negative, pose a big burden, and because of now the emergence of resistance, these organisms become more difficult to treat. So as we go ahead, you see gram negative organisms, they are associated with multiple drug resistance as well as extreme drug resistant, and now the phenotype is coming as a pan drug resistance. So there are very high burdens in ICU settings, specifically oncologies or transplant setting, and in ICU where prolonged ICU stays are there. If we see at ICUs or any oncology or transplant, gram negative as well as gram positive along with fungals are also there, but gram negative pose a big part, and it is because of irrational use of antibiotics are also contributing to that part. Now, how these organisms get either resistance? So resistance can be, they have in vitro resistance, so intrinsic resistance, or a resistance can be they can acquire. So how they acquired, like some bacteriophage mediated or plasmid mediated. So if you see irrational use, or now most of the farms which they use antibiotics for spreading or spraying of for fields for insecticide, or else because of that also now high level of resistance is coming up. So in gram negative, what are the most common gram negatives what we talk about? So gram negative, the most common burden we see in gram negative is most commonly Enterobacteriaceae. So Enterobacteriaceae is a very big umbrella. In Enterobacteriaceae, what are the common organisms we talk about is E. coli and Klebsiella. They are the most common organisms which we see in day-to-day routine. Other than that, Enterobacteriaceae has other organisms like Enterobacter, Citrobacter, Salmonella, Shigella also comes under umbrella of Enterobacteriaceae. Other than these Enterobacteriaceae, if we see microbiological how we classify these Enterobacteriaceae or how we classify gram-negative organism, they are mainly classified on the basis of their fermentation. So there are some organisms which ferment glucose, lactose, both fermenters. So they are known as fermenters. And there are some organisms which ferment glucose, but they don't ferment lactose. So they are known as non-lactose fermenters. And there are few organisms that they does not ferment any glucose. They will not ferment glucose as well as they will not ferment lactose also. They are known as non-fermenters. So as we know, in gram negatives, most commonly we see Enterobacteriaceae which are fermenters. So E. coli, Klebsiella becomes a very big part of that. And some non-lactose fermenters are Pseudomonas aeruginosa and Acinetobacter, which are we see commonly in a patient who has a prolonged ICU stay, or a patient who are neutropenic patients. Pseudomonas become a common organism, or a patient of burn. If you see these kind of patient, burn immunocompromised patients or a neutropenic patient, Pseudomonas we have to keep in our mind, along with our common Enterobacteriaceae, which is our gut pathogens. Then some rare non-fermenters are bacteria like Stenotrophomonas, Burkholderia, Elizabeth Kingae, then Kingella. These organisms are also there. We see when patient is a prolonged ICU stays, or a patient has some line catheter related, these infections are also seen. But most commonly what we'll focus on Enterobacteriaceae, which is a major chunk of gram negative organism. So first, before that, let's understand what is antimicrobial resistance. what is antimicrobial resistance? So as per the WHO definition of antimicrobial resistance is microorganisms that are not inhibited by achievable systemic concentration of the antimicrobial agent. So what does it mean? So I'll try to explain with an example. Okay, supposedly an organism X which require an antibiotic which is Y. So antibiotic Y, if to inhibit the growth of organism X, antibiotic required in a concentration of, for example, 64 microgram per liter. But whatever, if we give this antibiotic Y, it is not achieving, if it is achieving level up to 16 microgram only, it's not achieving 64 microgram in the blood. So this antibiotic will become a resistant. So as per the definition, this antimicrobial will become resistant for that particular organism. So this is basically definition of antimicrobial resistance. So now let's understand what are the multi-drug resistant, what are the extreme drug resistance, and what are pan-drug resistant. So as per the definition, multi-drug resistant organism which is non-susceptible to more than equal to one agent in more than three antimicrobial categories. So let's understand with an example. Okay, if even culture report suggestive of E. coli, in which if we see there is resistance to penicillins, there are resistance to fluoroquinolones, and there is resistance to aminoglycoside. So each one drug of each category is resistant. So now we have three categories which are resistant. Now they might be sensitive to carbapenems, they might be sensitive to our other tetracyclines, or phosphomycin. So if you have this kind of report which suggests you in more than one category of more than one agent in more than three categories, then it become multi-drug resistant. Then what is extreme drug resistance? If an organism which is non-susceptible to more than one agent but less than two categories. For example, let's see what we see most commonly is Acinetobacter in a hospital acquired setting. So in hospital acquired setting, Acinetobacter which is sensitive to only cholesterol or TG-cycline or minocycline out of tetracycline, rest all are resistant. So this kind of reports or this kind of organism becomes extreme drug resistant organism. And what is the example of pan-drug resistance? Is resistant to all antimicrobial agents. So we have no antimicrobial agent which is susceptible, so it becomes a pan-drug resistant organism. So these are the basic definition of resistance pattern. Now resistance can be natural or intrinsic, or it can be acquired. So what is the meaning of natural resistance or intrinsic resistance? Organism which is resistant to particular antibiotic by virtue of its composition. For example, let's see, gram-positive organisms are intrinsically resistant to cholesterol or estrogen, because cholesterol or estrogen has only activity for the gram-negative organism. So gram-positive organism will eventually or intrinsically they become resistant for these gram-positive drugs. Then other most important examples are for these two organisms. We have to remember these because everybody can remember that cholesterol and estrogen are not supposed to be given for a gram-positive organism. This is, I think, basic to understand. But these two organisms like Pseudomonas, which is intrinsically resistant to mainly ertapenem and tetracyclines like minocycline and TG-cycline. Other than this, amoxicillin and cefoxitin are also resistant because these are early generation penicillin, amoxicillin, and cefoxitin is also resistant. Cefamycins are also resistant. So, but for our practice, important thing is that they are resistant to ertapenem as well as tetracycline. So, if any microbiology report is suggestive of that, they have tested for them and they have find susceptible, so they should be intrinsically resistant. So, we are not supposed to give them for the Pseudomonas. And for the Acinetobacter baumannii, they are resistant to mainly Aztreonam and ertapenems. So these two, ertapenem, as we know, it's belong to the class of carbapenem. So as I'll go further, I'll tell about this beta-lactam. It's a big umbrella. So we'll talk about where ertapenem comes. But we see ertapenem, it's a carbapenem, but it is intrinsically resistant to two specifically Pseudomonas and Acinetobacter. So these are the example of intrinsic resistance. Now, what is acquired resistance? So acquired resistance, they can get resistant while they can adapt while getting mutation. The mutation can be mutational shift or drift, so they can get resistant. They can develop mutation in the particular gene. They can, because of shift or drift, they can get resistance. Or they can get by acquisition of foreign resistant gene by bacteriophage or plasmid, out of which plasmid plays a very, very big role for acquiring a resistance. But when organism get this kind of resistance, they have to pay some cost. So this cost could be because of fitness cost or some maintenance cost. Fitness cost means if they are getting resistance to particular group, like if they are trying and getting resistance for plasmid mediated, they are getting resistance for carbapenem. So sometimes we find that there are some drugs like chloramphenicol or some like phosphomycin or colistin, they are getting susceptible for this kind of drug. So this is known as fitness of cost. So for trying to get resistance for common antibiotics or a carbapenems or this, they become sensitive to sometimes this kind of drugs which are the one possibility is that these drugs are not used so much, so that's why they are becoming sensitive. So there is a theory behind it that's why I think this AMR weak concept is that we have to act now. We have to act now because we have to see, we have to maintain the stewardship. We have to make sure that the antibiotics used in the right way and right purposely and right dosing. Because if you see, if someone is because in the stress of this particular antibiotic, for example, a patient is started on a carbapenem, so on the stress of carbapenem, they get acquired the plasmid, get from some foreign plasmid, they get acquired this particular resistant to gene, and then they become resistant to carbapenem. But when we stop using this carbapenem, so eventually the organism will lose this plasmid and they will become again susceptible. So this is how we know okay, because these drugs which are not used nowadays, like chloramphenicol, fosomycin, which was not used, and colistin which was not used for so many years. Now we have options like this, and these drugs are becoming susceptible. The main reason is that we are not using these drugs. So under the stress, they acquire this plasmid. But if we remove the stress of that particular part, eventually they lose the plasmid. That's why we are making stringent antimicrobial stewardship programs. That's why we have to make sure what drug are we giving, whether we are giving the right dose, right drug is given or not. It is very important. And in acquired resistance, most important part is a single mechanism is seldom responsible for AMR, antimicrobial resistance in bacteria. There can be a many mechanisms. As we go ahead, I'll explain this part why I'm talking about there's single mechanism not responsible. There can be multiple mechanisms for resistance. As we go ahead, we'll see what are the different mechanisms. So this is the gram-negative organisms structures. So what is the basic difference between gram-positive and gram-negative organism is because of their cell wall. If you look at gram-negative cell wall and gram-positive cell wall, they both are made up of peptidoglycans, but they differ in their thickness. So what is the difference? Gram-negative has 1 to 2 layer of a peptidoglycan, while gram-positive has around 50 to 100 layer of peptidoglycans. That's why they are more thicker. Gram-positive cell wall is more thicker. And hence we see for the gram-positive organism, whatever the antibiotics we have, they mainly act on cell walls as compared to gram-negative organism. And another difference in structure of gram-negative is there is a gram-negative is an outer membrane which is absent, or which is gram-positive organism that they lack this uh, outer membrane. So let's see if we see how particular drug enters and act and how these drugs can get resistance, which is our main important motto for today's lecture. So if we give any antibiotic, for an example taken beta-lactam, so beta-lactam antibiotic will enter. So for entering into bacteria, they need some pathway. So what is that pathway? That pathway is porin channels. So via porin channels, antibiotic enter into the bacteria, they go into the periplasmic space. So for entering, they require porin channels. After entering, they are from periplasmic space, they go to their particular binding site. Sometimes the binding site on the inner membrane, which is for the beta-lactam sort of penicillin, this binding site, or this site is known as penicillin PBP, penicillin binding protein. Or some antibiotics like fluoroquinolones or TMP-SMX, Bactrim DS, which is act on your DNAs. So mainly they go and they enter, or macrolides, for example, they go into the cell wall, or they go into the nucleus or ribosomes. 30 some antibiotics bind on 30th subunit of ribosome, some bind on 50th subunit of ribosome. So they enter and they particularly bind to their binding site and they will act. So this was the mechanism of entering. So where they get resistant, how they get resistant. So for entering into the into the bacteria, they require porin channels. So if these porin channels are get modified, as you can see this in this picture, with the red one which is marked with the arrow, this porin channel is modified. So a particular drug beta-lactam will not able to enter, but in front of that you can see there is a porin channel and beta-lactam can easily enter into that. But if this porin channel is modified, so this is known as because of this, their permeability to enter will be reduced. So this is not decreased permeability or outer membrane permeability. So by modification, they can get resistant. One mechanism there. Once they enter, they can kick out. They all can be kicked out by efflux pump. So these pumps are known as efflux pump. They can kick out all the antibiotics. So we'll see efflux pumps are important in which kind of organs, or why we need to know about these efflux pumps. We'll go ahead and we'll see in further discussion why these are important. So if they can be kicked out by the efflux pump. Once they entered into periplasmic space, there are some enzymes. For what most commonly we use antibiotics are beta-lactam antibiotics. So for these beta-lactam antibiotic, there are some enzymes which are known as beta-lactamases. They will degrade them. So these can be the antibiotic can be resistant or they become resistant by enzymatic degradation. So third important part is enzymatic degradation, and fourth one is where they bind. So there can be modification of their binding site. So these are the most important four mechanism by which an antibiotic can get resistant to a particular organism, or a gram negative become a resistant to an antibiotic. So what are these? First, there can be modification of porin channel. Second, after entry, they can kicked out by the efflux pumps. Even if they entered, there can be degradation of enzyme. For example, like beta-lactams enzymes, we will be focused on that part. And one and last one is modification of their binding site. So these are the most four things for which by which an organism like gram negative organism become resistant. Now we see ki, as I told ki, and most commonly we will focus on beta lactams because beta lactams play a very big role in gram negative organisms. So we'll go ahead. So these are the four mechanisms, as I already told: enzymatic degradation, efflux pump, decreased permeability, and altered binding site. For a gram negative organism, most commonly affecting their activity or making them resistant is enzymatic degradation. In some organism, we'll discuss ahead ki efflux pump can play a very big role in some organism. Then efflux pump, and then decreased permeability. There's modification of porin channel and altered binding site. Usually, alteration of binding site, making it resistant, will be seen in mostly gram positive organism. But this modification is also playing very important role. I'll tell you where. In further slides, I'll tell you where this modification has made a very important antibiotic resistant to it. So these are most common four mechanism. So to understand this, let's see for the beta lactams, if, as we know, as I told, beta lactam has a very big umbrella. So to understand what are the beta lactam antibiotics, so in beta lactams, starting from penicillins like early generation penicillin, penicillin G, penicillin V, then after that comes aminopenicillin, amoxicillin, ampicillin. Then after that, there are some uridopenicillin like ticagrelin, penicillins, which we use. Ticagrelin is not used, piperacillin we are using. Then there are some anti-staphylococcal penicillins like nafcillin, oxacillin, cloxacillin, dicloxacillin, flucloxacillin are there. And then commonly used, I think most commonly used, or abuse will be wrong word, but commonly used is carbapenems like meropenem, imipenem. There are some carbapenems which are not used like Durlopenem we are not using. Ertapenem we use. So meropenem, imipenem, ertapenems are the three penems we are commonly used. And there are some misconception about ferropenem. It's not, and it has a penem ring, but it is not a oral form of carbapenem. I think most of people misunderstood that the ferropenem is a oral form of carbapenem, but it is not. It has a spectrum of activity up to amoxicillin, clavulanic. This is the spectrum of ferropenem. It's not an oral meropenem or oral carbapenem. So many people have a misconception about ferropenem. It's an oral carbapenem, but it is not. It just have a penem ring. For the classification, they have given name because all they, as we know, beta lactam rings are there. So that's how they are called as beta lactam. So along with them, they have penem ring in their structures. All carbapenems have meropenem, imipenem, durlopenem, ertapenem. So same ferropenem also have an enum penem ring, but it doesn't make equivalent to a carbapenem. It doesn't spectrum of and doesn't come into the classification of carbapenems. Then monobactam in beta lactams, monobactam, which is example is astroenum. So why we need to know this spectrum? So there are some enzymes, as we were talking about, enzymatic degradation plays a very important role in gram-negative organisms. So these enzymes, if they are inhibiting only penicillin, then they are known as penicillinases. If they are inhibiting up to third generation of, including all penicillins, and they are inhibiting up to third generation of penicillin, then they are known as AmpCs. And if they are inhibiting up to all cephalosporins, including fourth generation of cephalosporins, then it will become extended spectrum beta-lactamases. And if they are also inhibiting carbapenems like meropenem, imipenem, ertapenem, then it becomes carbapenemases. So most important, what we are dealing nowadays in patient is with carbapenem resistant organism, or the organs which are producing carbapenemases. So to understand this, what are penicillinases, what are AmpCs, what are ESBLs, what these enzymes are, I know it becomes tough to understand all this, but I'll go slow and I'll try to make you understand what are these. But if you understand this basic thing, then it will become very easy to understand which drug to use and what to use. So to classify these enzymes, there is classification which is known as Ambler's classification. It is four class: class A, class B, class C, class D. So basic difference between all classes. So they have class A is a very distinct class. It will contain right from penicillinases up to carbapenems. It has all spectrums. If you see class B, which is the basic difference between class A and other classes, okay, they have zinc residue. Okay, these are metals. They have metal residue. All others are serine based. This is a zinc based. So that's why class B are known. These enzymes are known as metallo-beta-lactamases, MBLs. They are also called as MBLs, and these all MBLs are carbapenemases. So basic example, you will see NDM as an MBL, which is very common in India, and it was first found in an Indian patient who has traveled to New Delhi, and then he again went to the US, and then it was found. That's why it was named as New Delhi metallo-beta-lactamases, NDM. It is very commonly you see, if you see reports which shows enzymatic patterns also, so you will find out NDM is a very common, and it is carbapenemases. So it will inhibit up to the carbapenem. So class B, all another example of NDM, then IMP and WIMP are also example, but we don't see IMP and WIMP. We see mainly NDM. So class B, what is the difference from other classes? The class B is a metallo-beta-lactam. It has a zinc residue, and they are all carbapenemases. And most commonly, what we deal in India is NDM. What about the class A? Class A have many enzyme. I'll try to classify further also about the class A and class D. Class D is also containing oxas, and these oxas are most of these oxas are also carbapenemases. So if you look at this classification, class A and class C are different. Class B, the main difference is of class B, which is making it distinct from other classes. It has a zinc residue, and they are all metallo-beta-lactamases, and they all are carbapenemases. Class D also carbapenemases. Mainly these are known as oxas, and different organism has different oxas. So I'll go ahead in the classes, then I'll tell you which oxas are there in which organisms. So class D as other oxa, they are also carbapenemases. Now class C's are known as AmpCs. These MCs are usually part of ESBL, but they only, as we have seen for earlier, the class MCs will up to third generation of cephalosporins. They will spare cefepime and carbapenem. So if there is an MC production is there, so we can use carbapenems and fourth generation cephalosporins, which is cefepime. So this is class C, and there are some organisms I'll talk about when I talk about MC. I'll tell you which organisms we have to think about MCs and where we can find MCs. So whenever there is a MC production is there, the drug of choice will become either fourth generation cephal, because they will not inhibit fourth generation, which is commonly used. Fourth generation is cefepime, and carbapenem will become their drug of choice eventually. And class A has all type of enzymes, starting from penicillinases up to ESBLs. So let's see about the class A. So this is which enzyme does class A contain. So group A has ESBLs, mainly ESBLs. I'll tell you which ESBLs are more common. So which are in red, they are more important ESBL for us, which we see routinely. TEM, SHV, CTXM, PERWeb, JESBES. These are ESBLs, out of which all are not ESBLs. There are some enzymes like SHV and TEM. I'll explain further. They may not be ESBL. What does it mean? ESBL means they will inhibit up to fourth generation of cephalosporins. Like your up to fourth generation of cephalosporin, all will become resistant. But carbapenemases, up to carbapenems, they will make resistant. So KPC is a group A carbapenemases, which is usually, luckily in India, we don't have more of KPCs for carbapenemas. We have more of class B and class D. Class A carbapenemases are not seen in India. KPCs are very rare in India. But what we have as a carbapenemases are class B and class D. Oxas and NDMs we have more commonly. Capacities we don't have. But what we have more commonly is ESBL. So if you look at recent ICMR data, which suggests that 40% ESBL rates for in E. coli is in India, and 60 to 80% rate of ESBL is in Klebsiella in India. So in community acquired, I'm talking about. In hospital acquired, most of they are carbapenem resistant, but in community acquired also they are ESBL. So it is very important for us to understand what is ESBL pattern. If we see and for this we also need our hospital's antibiogram. So if you see up to third generation of cephalosporin or fourth generation of cephalosporins are resistant, we are seeing this kind of pattern. So it obviously tells us now we have to think about which is our drug of choice. If patient comes in septic shock, which should be used as a drug of choice. If we see our ESBL pattern is low, then we can choose. No, we can spare our carbapenems for our starting. We can use some drug like piperacillin. Or if a patient is on, we know there is no antibiotic exposure, we don't think a patient will have this kind of resistant pattern, we can start with the ceftriaxone also. So this can be better understand along with your antibiogram. So most commonly group A ESBL, TAM, SHV, CTXM, it is very important for us. Per and web, usually they are produced, they are ESBLs of Pseudomonas. It's not like that other Enterobacteria cannot produce it, but it is most commonly seen with the Pseudomonas. And Pseudomonas can also have a TAM, SHV, CTXM, but most commonly Pseudomonas will have per and web as in their ESBLs. Okay? Now let's think about what we know about SHV. So in SHV, practically they may not be clinical practice. They may not always be ESBLs. They are like sometimes they can be penicillinases, or along with penicillin they can be resistant to early generation of cephalosporin, like first generation, second generation cephalosporin. They will be resistant. Like ceftriaxone, ceftazidime may work in SHVs. Okay, in our experience in my previous hospital where I've seen all most of the data, we find out that there are more non-ESBL than ESBL. What I mean by non-ESBL is like they might be resistant to some penicillin or some early generation cephalosporin, but they might be sensitive to ceftriaxone. Ceftriaxone might be working, but if they are ESBL, our ceftriaxone, including our cefepime, will not work. So they are mainly, most commonly, they are non-ESBL than ESBL. So now I want to focus on what I mean by tazobactam works, but avibactam is more potent. For this, I like to make you understand that there is something known as K-Cat by Km ratio. So what is K-Cat by Km ratio? It's usually a enzymatic. You see in any enzymatic reaction, it is K-Cat by Km ratio is used. It means ki K-Cat by Km is ki how much an antibiotic is substrate for particular enzyme. It's for an enzymatic degradation. Like a particular antibiotic can degrade how fast or how fast it can degrade the particular enzyme. And this enzyme can degrade antibiotic. Kitna, so the bigger the K-Cat by Km ratio, it means ki the substrate is more potent for that particular beta-lactamases. And so here we are, and how can we understand that beta-lactam is an antibiotic, beta-lactamase is an enzyme. Supposedly a beta-lactamase enzyme can how potently destroy the particular beta-lactam. It will suggested by K-Cat by Km ratio. So if you looked at, for example, SHV, for SHV, early generation penicillin like benzyl penicillin have a higher K-Cat by Km ratio as compared to ceftriaxone or as compared to ceftazidime or cefepime. So that's how we know this K-Cat by Km ratio helped us to understand that these enzymes can be ESBLs or they are non-ESBL. So this is what is about the K-Cat by Km ratio. And there's one entity which is known as IC15. IC15 is its key. It will suggest how potent and beta-lactamases inhibitor against the particular beta-lactam. So if we look at the potency, the lowest IC15 means ki how much amount of beta-lactamase inhibitor is required to inhibit particular beta-lactamases. For example, how much amount of tazobactam will require to inhibit SHV enzyme. So the lower IC50 will tell us more potent particular beta-lactamases inhibitors are. So what are the most commonly beta-lactamase inhibitors we use in day-to-day? We use clavulanic acid, we use sulbactam, we use tazobactam, and we use avibactam. There are some other beta-lactamases inhibitors are there like relibactam, weberbactam. These are usually used in Western worlds because I'll go ahead while these are not available in India and they are not useful in India. Relibactam and weberbactam. What is more relevant for us now, which is coming, is zidibactam. So these are, but what we use most commonly are clavulanic acid, sulbactam, tazobactam, and avibactam. So we need to know which is more potent for them. So how we know which is more potent? So we get an idea by IC50. So IC50 is lowest for avibactam as compared to tazobactam. For the SHV enzyme, tazobactam will also work, avibactam will also work, but avibactam is more potent because if supposedly SHV becomes an ESBL, then activity of tazobactam may be questionable. So let's take an example of another TEM. So what is TEM? TEM is actually named got because of one patient whose name was Temonera. So after that, the name was given TEM enzyme. So TEM, initially when it was discovered, it was known as TEM1, which spared ceftazidime and cefotaxime. That's how we get to know that this is a different enzyme than SHV. So in early generation or early generation TEMs over there, now there are many variants, up to 50 variants are there for TEM. So TEM1, initially it can spare ceftazidime and cefotaxime. So hence TEM may or may not be ESBL. If they are inhibiting ceftazidime, cefotaxime, ceftriaxone, then or cefepime, they become ESBL. If they are sparing them, then they are non-ESBL. So now ESBL variants are there. And as we know, if we check IC50, avibactam becomes the more potent BLI, but tazobactam will also work. Clavulanic might not work, and sulbactam might or might not work. But out of most commonly used piperacillin tazobactam, what we use day in day out. So tazobactam might work against TEM also. Now, this is the most common ESBL. This is CTXM is there. It is 100% in ESBL. ESBL, it is extended spectrum beta-lactamases. It means it will inhibit up to fourth generation of cephalosporin. So why we are focusing about only third and fourth generation of cephalosporin? Why not fifth generation of cephalosporin? We know there are 5 generations of cephalosporins, right? But what is more important about fifth generation cephalosporins are cephalosporins of fifth generation like ceftaroline and ceftobiprole. They have gram negative activity up to third generation like ceftriaxone, ceftazidime. They have activity like gram negative. What additionally they have? They have an anti-MRSA activity. So that's how they make it different of class fifth generation cephalosporin. So when we talk about extended spectrum beta-lactamases, we talk about fourth generation only in view of gram negative, because if you look at fifth generation, they have an activity of up to third generation only. So that's why fourth generation become a more good option in a gram negative organism, right? That's why it's very important to know that whenever we see cephalosporin from class first generation to third generation, what happens is gram negativity activity increases, gram positivity activity remains the same. But what is the difference of fourth generation and fifth generation? Fifth generation is gram negative activity is equivalent to gram third generation, but they have an anti-MRSA activity. That's why when we talk about extended spectrum or ESBLs, they can inhibit up to fourth generation of all beta-lactams, right? All cephalosporin up to fourth generation they will inhibit, including from penicillins, but they'll spell carbapenems. Meropenem, imipenem are usually spelled. They have a very good MIC, but some CTXM variants are there. Most common we see in India, CTXM 15 variants is there, which is more common in India. And sometimes a strong CTXM 15 might increases some MICs for artapenem. So you can see the report of an E. coli which is resistant up to 4th generation of cephalosporin. Meropenem, imipenem is sensitive, but artapenem is intermediate. So in this, by looking at phenotype, we can think it can be a CTXM variant, which can increase the MICs of artapenem, right? And meropenem, imipenem are usually, they have better MICs. Amongst beta-lactam inhibitors, avibactam becomes the more potent. In this, if we see the IC15 value, avibactam has the lowest, then tazobactam, then sulbactam and clavulanate might not work against them. So that's why sulbactam, tazobactam might work, but it depends on which variant of ESBLs we are seeing. If it's because of SHU or TEM, tazobactam, sulbactam might work. But if we are seeing CTXM15, then there are chances that they might not work, but avibactam will work. And that's why pipta susceptibility or piperacillin tazobactam susceptibility remains uncertain, because we don't know whether it will become susceptible or whether. So that's why on the basis of phenotyping only we can say it is susceptible or not. So this is the basic of CTXM enzyme. So, but now CTXM, we will not use avibactam. As you know, out of all, we have seen all class A ESBLs, we have seen SHU, we have seen TEM, we have seen CTXM. We know that avibactam is more potent against all these enzymes, but we will not use avibactam because we want to preserve these avibactam for the organism which are carbapenem resistance. So for this ESBL pattern, the drug of choice eventually becomes your carbapenems, meropenem or imipenem. So this becomes a drug of choice for them as per the recent IDSA guidelines. And there was one trial for this. There was a trial which is known as Merino trial, which told us about activity piptas versus meropenem for an ESBL pattern. So we find out that meropenem is superior to piptas as per this Merino trial. It told us but there were some caveats because piperacillin tazobactam was not used in full strength. What is the full strength of piperacillin tazobactam? Is 4.5 grams Q6 hourly in an infusion. Always remember beta-lactams has to be given in infusion because their activity is time above MIC. So they have to remain a particular time duration above the MIC. So always remember beta-lactams are supposed to be given in infusions. They are not supposed to be given direct push. They are not supposed to, because they have a time above MICs. So for the Merino trial, we find out that piperacillin tazobactam was not used in 4.5 gram Q6 hourly for a prolonged infusion. It was not used. So we don't know. Let's see if further trials tell us head-to-head trial about piptas and meropenem. But right now, as per the guidelines, if we see ESBL organism, if you find out there is an ESBL organism, then we have to choose carbapenems as our drug of choice, not piperacillin tazobactam, as per the IDSA guideline. Right. So let's see class A enzymes. about tazobactam and avibactam, because ceftazidime-avibactam is most commonly used, and as well as piperacillin tazobactam is most common. Let's see the difference, which enzyme they can inhibit. For example, CTXM, as I told you, they are uncertain, but avibactam definitely have an activity. SHV, usually yes, may or may not. As we told, if they are non-ESBL, tazobactam will work. If they are potent ESBL, they might not work tazobactam. Same goes for TAM also. But if you see, avibactam is active against all. But when we come to carbapenemes like capices of class A, we find out that this tazobactam doesn't work against carbapenemes, but avibactam, yes, it works against carbapenemes. That's why ceftazidime-avibactam combination, or now there is new combination has arrived, aztreonam-avibactam. So we have to preserve this aztreonam-avibactam for carbapenemes organism. We have not, because an organism which is having CTXM, SH10, we can use carbapenems as a, we have to preserve this ceftazidime-avibactam or aztreonam-avibactam drug for that particular, and for carbapenems production. As I told, there are some enzyme like porin web which was produced by Pseudomonas, and Pseudomonas more commonly produce this kind of ESBL, and against this ESBL tazobactam will not work. As we told, that's why we say piperacillin tazobactivity may be uncertain against ESBLs. Because of that, porin web may not be get inhibited by our tazobactam. And about avibactam also, its activity is uncertain, specifically against the web. It might not get inhibited by avibactam also. So this is, now as I told you, these are the different classes. As I was talking about, class A has a very distinct from, right from penicillinase up to cephalosporins. Class B, they are all, and class B all are carbapenemases. So tazobactam and avibactam, relibactam, weberbactam, we don't have much importance in India because we don't have capices. They are mainly active against capices. That's why class A ESBL and class A OXAs, if you see, these are very good. Class A carba. That's why in class A carbapenems, capices, as we see, so capices are more predominant in Western world. That's why relibactam and weberbactam are more used in Western ones, and that's why we have, as carbapenems, we have NDM and OXAs. Class B and class D, we have more predominantly. And if you see, relibactam and weberbactam doesn't act against class D, so it's useless for. Now, I would like to emphasize on class B, NDM. You see, any beta-lactamase inhibitor will not work against NDMs. They'll not work against. So NDM is the only beta-lactamase against which no beta-lactam inhibitors can inhibit them. But now we have one drug which is aztreonam. NDM doesn't affect aztreonam. NDM is not a substrate, or avibactam, aztreonam is not a substrate for NDM. So in the presence of NDM, aztreonam will work. But the problem with the aztreonam is all other ESBL can inhibit aztreonam. So if an organism which is showing only NDM in your report, if you've done genotypic testing, like I'll tell about some genotypic testing. If you've done genotypic testing for an organism which shows E. coli, it's only showing NDM, then only NDM is there, then you can use aztreonam, because NDM will not affect aztreonam. As we see, avibactam is also not act against NDM. Or class B, all these MBLs, no BLI will act against them. All BLIs are ineffective in presence of class Bs. So only drug which can act against them is aztreonam. So hence, if we have some other class along with NDMs, like as I told previously in my slide, as I told we don't find a single mechanism for antimicrobial resistance. Like an organism like E. coli or a Klebsiella, along with NDM, they might have class D oxas, or they might have some CTXM of class A. So they might have class A plus class D enzymes are there. So there are some tests. How we know if I'm talking about all these can be present? So how we know? There are some tests. So how we do in a good centers, what we do when we send the blood culture of a particular patient, we send the blood culture. Blood cultures are put in some backtech machines. So this machine will detect if there is a growth of organism. Because of this organism, they produce some byproducts, and these byproducts are sensed by these machines, which are known as backtech machines. So once they flag positive because of their activity, they produce some byproducts, and this byproduct are sensed by the machine, and the machine's bipped. Okay, it is something is growing. So after this, what do microbiologists do? They put a slides and they do staining, and after staining they tell us whether there's a gram positive organism or there's a gram negative organism. After that, this bottle which is flag positive, after which smear are made, and then these are made on a culture plates, and then they are put for culture in an incubation for a culture growth. Then in a conventional method, they will take time around 24 to 48 hours. There will be growth, and after 24 to 48 hours, then we'll put an antimicrobial disc for resistance pattern, where sensitivity pattern. We will do curly burst disc pattern is known as. We put the plates, and then we'll know that this particular antibiotic is sensitive, this particular resistant. This is a conventional method how your culture sensitivity report comes. That's why it takes around 4 to 5 days. When we say it takes around 4 to 5 days, so how to reduce this time when we are working in the ICUs, or when we are working in a patient where we don't have 4 to 5 days? So now there are some methods which are there, which at least reduces this particular time. How? There are some methods, like now there is something known as carba R test. When we know there is a growth are there, these growth are put on a mildit of machine, and there is star carba test, which will tell you ki imipenem is hydrolysis or not. If imipenem is what? Carbapenem. If carbapenem is hydrolyzing, means carbapenem is destructing. So whatever the organism it is there, it is inhibiting the carbapenem. So we can choose accordingly ki what antibiotic we have to choose. So we will not use carbapenem in that. So it has reduced our time. Now there are some panels are there, molecular tests like BCID2 panel. I think most of the people who are working in ICU knows about BCID2 panel. So BCID2 panel is a biofire panel. What we do, once blood culture is flagged positive, we send it for this BCID2 panel. BCID2 panel will identify the organism, and they will identify these 5-6 enzymes like CTXM, NDM, OXAs, and your TEM. These enzymes can be, and WIMP. These enzymes can be identified by this biofire panel. So it will tell us which organism is there, which enzyme is there. So it reduces our time of 3 to 4 days. So 3 to 4 days prior of our conventional method, we know that this organism is carbapenem resistant organism. And if we know these enzymes, that's why in ICU practices, we should know about these things also, okay, what to send and how to send and how to interpret these particular things. If we see BCID2 panel was sent, and an organism came as a E. coli, which is only producing CTXM. So as per our classes, we know that CTXM is an extended spectrum beta-lactamases, and E. coli. So E. coli will be, we're expecting in a phenotypic report, which we'll get after 48 to 72 hours. So likely if we have this genotypic pattern is there, it means it will express, most likely it will express in a phenotypic also. So we are expecting ki this organism are up to resistant up to cefepime. So our drug of choice become carbapenem. For example, if this E. coli are also having along with CTXM, it is having NDM also. So we know this CTXM will inhibit up to all, but avibactam will, ceftazidime avibactam we can use. Yes, we can use ceftazidime avibactam for ESBL. Yes, definitely. But what about NDM? NDM will destroy ceftazidime. So in this thing, we have to use astronome, because ceftazidime avibactam will take care of your CTXM or other enzymes. NDM will destroy ceftazidime, so it will not work. So for NDM, we need something which is standing against NDM. So astronome. So here, hence astronome avibactam or ceftazidime avibactam astronome combination was used or came into use. So these methods like biofire, BCID2 panel, or there's something known as molecular sepsis flow. Sepsis flow has more variety of gram-positive and gram-negative organism identification as well as enzymatic panel. It is a more enzyme as compared to BCID2 panel. So these are some molecular tests now which has evolved, which will tell us around 48 hours to 72 hours prior what we'll get after conventional report. So this is why we need to know about this enzyme. When the person who are working in the ICU, they should be acclimatized about these things. What is CTXM, what is NDM, what is OXAs? Because if you send these panels, so you will get in 48 hours of margin. If you don't have these panels and you started patient on if patient comes to you with septic shock, you started patient on a meropenem. But if you send blood culture is growing, it will take around 48 to 72 hours to let you know whether this meropenem will work or not work. But if you have these panels in with you, if you have this BCID2 panel, or if you have sepsis flow in your test labs, or if you can send this, so 48 to 72 hours prior, you will get to know whether this carbapenem will work or not. So accordingly, you can act. You will know the organism also, and you will know the enzymatic pattern also, so that you will have a margin of 48 hours priorly. You can start on particular antibiotic. So this type of molecular test will help you to give an antibiotic. So to knowing that, you have to be acclimatized with all these enzymes. What is class A ESBLs are there? What is class B NDMs are there? What is class C AmpC is there? And class D oxide enzymes are there. And what are class A carbapenemes? So that's why I need to focus on these enzymes. It is very important to understand when we work in this kind of settings where we need to get a report 48 to 72 hours prior what we get from the conventional method, right? So this is what I was talking about. Now class D. So as I was talking about, class D has an OXA enzyme. It is an OXA families, oxacillinases. It is actually basically known as oxacillinases. It contains oxacillin. So most commonly what we see in Enterobacteriaceae oxas like E. coli, Klebsiella, Enterobacter, Citrobacter, they have an OXA-48 family against which our Abactum is nicely at work. But what about Pseudomonas and Acinetobacter oxas? I'll discuss ahead what are the mechanism in Acinetobacter and Pseudomonas and what are their oxas. But Avibactam fails against Acinetobacter oxas and Pseudomonas oxas. It will only work against Enterobacteriaceae oxas. For example, if you send a patient sepsis floor BCID to panel, organism turned out to be Acinetobacter and it is showing OXA-23 or whatever oxas and some NDMs. So we want to use Septagenobacter, will it work? No, it will not work. Why it will not work? I'll tell you for the slide. But if you know that Klebsiella is there, or Citrobacter is there, or E. coli is there, and if it is class D enzyme, so we know that Ceftazidime avibactam will work because avibactam will inhibit. But along with class D oxa, if they have class B also, which is NDM, then avibactam alone will not work, and we need something which can stand NDM or class B, as we told, and astronam. So hence, combination of astronam bactam or Ceftazidime plus astronam combination has play a role when patient has. Along with class B, if there is some class A or class D enzymes are there, then this combination is used. And if only class A and class B are there, then what we use? I'll show you one good slide ahead, which will simplify whatever I was telling right now, which will be simplified and better to understand. So as I was telling you, most commonly what we are dealing nowadays or what is difficult to treat is our carbapenemases. So what are carbapenemases? As per the Ambler classes, class A में KPCs, there are some other EMEs and JES are there, but we don't see JES much in our settings. KPCs are more common and which is seen in mostly in Western worlds. Class B, which is predominantly in India, is NDM. WIMP and IMP are there, but IMP and WIMP we don't see much. But what we see is class B NDM. It is very predominant in India, and NDM is, you see, all Enterobacteriaceae, NLF, or lactose fermenter, non-fermenters, even with the Pseudomonas, even with the Acinetobacter, even with the Enterobacteriaceae, NDM is predominant in India. So that's why class B. That's why it become a very important to know which type of resistance pattern is there in our gram-negative organisms. And class D oxas, most commonly OXA-48 family in Enterobacteriaceae. I'll discuss further which Pseudomonas have which oxas and Acinetobacter which oxas. Other than this, how carbapenem, other than this enzymatic degradation, what are the other methods this carbapenem will become resistant? So porin channel mutation, specifically porin channels are there in Pseudomonas. There are some porin channel, they are modified porin channels. They will have resistance to meropenem and imipenem. They get resistance to this carbapenem. They are known as modified porin channels. And there are efflux pumps. As I told you, efflux pump, what will do efflux pump? It will kick out all the antibiotic. So porin channels and efflux pumps become an important part of resistance in cases of Pseudomonas. But when we talk about E. coli, Klebsiella, Enterobacter, Citrobacter, these Enterobacteriaceae, enzymatic degradation is a most important part. But when we talk about Pseudomonas, we have to remember in a case of Pseudomonas, if there's a carbapenemases production are there or carbapenemases are there or carbapenem resistance are there, then porin channel and efflux pumps become a most important part along with other enzymes with NDM. These are very commonly seen in Pseudomonas. And in Acinetobacter, along with class D, there are different oxas are there. So we'll see it. So that's what I was talking about in Pseudomonas. Efflux and porins are predominant mechanism. Then other mechanisms for how they get resistant is AmpCs. Now for the AmpCs, I want to focus. AmpC as we talked about as per the Ambler's classification, it is a class C. Class C AmpC, and it is up to third generation of cephalosporin. It will inhibit all the cephalosporin, and cefepime and carbapenems are spared. So what are the organisms which produces AmpC? This is very important for us to remember. So it's a trick. Spice organism we remember by the spice. S for Serratia, P for Pseudomonas, I for indoor producing Proteus and Morganella, then C for Citrobacter, and E for Enterobacter. So these are spice organisms: Serratia, Pseudomonas, indoor producing Proteus and Morganella, then your Citrobacter and Enterobacter. Now, Enterobacter aerogens has recently renamed as Klebsiella aerogens. So, Klebsiella is not always Klebsiella pneumonia. Make sure it's not Klebsiella aerogens, because Klebsiella aerogens, which was previously known as Enterobacter aerogens, now renamed, and this is a spice organism. This comes under spice organism. So, what is the significance of this spice organism? This spice organism, what they have? They have an inducible AmpCs. Like as I told you, intrinsic resistance as well as acquired resistance, right? So inducible resistance means after in the stress of some antibiotic, they will induce AmpCs and they will become resistant. For example, I'll give you most example of that. Okay, I had one patient in which urine culture was showing sensitive Pseudomonas organism, which was sensitive to piperacillin tazobactam and carbapenems. So, and physician started on patient on a piperacillin tazobactam for a pyelonephritis. After day 7, patient again started to develop fevers. We have repeated the cultures and we find out that piperacillin tazobactam and this organism same grown Pseudomonas aeruginosa, it was resistant to piperacillin tazobactam. So what does it explain? It explained that there is a production of MCs. So in the presence of some antibiotic, specifically early generation penicillins like cephalosporins and penicillins, or in presence of carbapenems like imipenems, in the presence of these particular organism, like I told, spice organism, they will produce AMCs, and these AMCs will destroy these organisms. And as we discussed in a previous slide, tazobactam will not inhibit this MC. Hence, piperacillin tazobactam will fail. And as we find out, piperacillin tazobactam was resistant in. So, for this spice organism, always remember Serratia, Proteus, Pseudomonas, Proteus, Morganella, Citrobacter, Enterobacter, and specifically Klebsiella aerogens. Klebsiella aerogens is now Enterobacter aerogens. But previously it was Enterobacter aerogens, now it is Klebsiella aerogens. These are spice organisms, and on the presence of particular antibiotic, they can produce AMCs. So whenever treating with these organisms, either choose cefepime if susceptible or carbapenems if they are susceptible. Don't go for early generation cephalosporin or piptas, because they on therapy they will develop MCs, they will induce MC, and they become resistant to particular these drugs. That is a very important thing about MCs. And as I told you, Pseudomonas mainly have an efflux pump along with NDM, and there are some Pseudomonas oxas which are OXA 2, 5, 10, and 50. Out of which OXA 2 is more common and OXA 10 is very common, along with efflux and NDM. So hence, Pseudomonas we don't have much therapy to treat with. So whenever we see Pseudomonas resistant, all these things, there are efflux, so all these antibiotics, all our beta-lactams are kicked out of this. Now we have one antibiotic which is pipeline, which is known as cefepime zidibactam. As it works on zwitterion, it get escaped of efflux form. So cefepime zidibactam is one option. Cephadoricol also doesn't act good against NDMs of this and oxas of usually of Pseudomonas. Mainly efflux is there. Cefepime zidibactam is one option, or other option is polymyxin based therapy. So these are only two options are available for Pseudomonases. Whenever we deal carbapenem resistant Pseudomonas. So Pseudomonas, when we see Pseudomonas, either it can be sensitive, pan sensitive, or if it is carbapenem resistant, so it can be anything. So that's why, and there are no mechanism to get whether this Pseudomonas is producing efflux or where there is porin mutation are there. There are no mechanism to, unless and until we do gene sequencing, in which we know that there is porin mutation is there or AMCs NDM, but efflux we cannot know if we are resistant to this. So how to check in clinical practice that there is resistance other than this? For example, if as I was telling you, if there is NDM plus some like PER or some other ESBL of Pseudomonas is there, and we see that all drugs are resistant, so we do this synergy testing, synergy of ceftazidime plus aztreonam. As I told previously, along with NDM, if there is some ESBL are there, then we use this combination, which will work. But if there are efflux pump is there, so this all antibiotic will be effluxed out, hence it will be resistant. But if there is no efflux and there is only enzymes like NDM plus class A, which will be inhibited by avibactam, and aztreonam will work against NDM. So this is how we can tell if efflux is there or not. If this synergy also fails, this is an indirect way to extrapolate that there is efflux pump. So always remember, whenever you are treating Pseudomonas, always remember that the resistance mechanism is efflux and porin channels, which is very important whenever you're dealing with them. So for them, drug of choice, either polymyxin based therapy you have to go, or now cefepime zidibactam. I think in the coming 6 months we'll have an cefepime zidibactam along with us. So let's talk about Acinetobacter. Acinetobacter, usually if we talk about community acquired Acinetobacter, we are not worried because it's mostly sensitive. But the more problematic part is carbapenem resistant Acinetobacter, which is known as CRAB. So it is very predominant in hospital acquired setting, like hospital acquired pneumonia or line related infections, or wherever there is a prolonged hospital stay, Acinetobacter is there. And this Acinetobacter, more than 98% of hospital acquired Acinetobacter are carbapenem resistance. So now, can we use whatever we are talking about, like ceftazidime aztreonam against all these what we are talking about? Because in them there are predominant mechanism is along with NDM there are oxas, and their Acinetobacter oxas are 23, 25, 51, and 58. These oxas avibactam will not work. And Another thing is Astronam is intrinsically resistant to Acinetobacter. Hence, this combination of Ceftazidime Avibactam plus Astronam or Astronam Avibactam combination, what we are using for carbapenem resistant, like E. coli, Klebsiella, whatever we are using for them, now we cannot use because Astronam is intrinsically resistant to Acinetobacter and Avibactam is not going to inhibit. So for this carbapenem resistant Acinetobacter baumannii, now what we have therapy is what IDS is suggesting, either you choose polymyxin based therapy as a backbone along with combination of either high dose of sulbactam, which usually good, and sulbactam. About sulbactam, now I would like to highlight here with sulbactam we not use as an only BLI. Sulbactam has some antibacterial activity for acinato also. Hence we use sulbactam combination, and in this sulbactam is not like what we are using cephalosporins sulbactam or this, not that kind of sulbactam, only sulbactam in a high dose sulbactam. So there are only sulbactams are available, so we go with either polymyxin plus sulbactam or chances of minocycline or TG-cyclines if they are susceptible, according to if they are treating bacteremia or whether we are treating some like pneumonia, then TG-cycline is better. If you are treating bacteremia, then as we know, TG-cycline completely goes to the tissue. It doesn't remain in the blood. So TG-cycline for any bacteremia. Do not use TG-cycline for any bacteremia. It rapidly goes into tissues. It doesn't remain in the blood. So hence, if you are using for bacteremia, don't use TG. Use mino if it is susceptible. So along with polymyxin, either use for sulbactam or a tetracycline. For tetracycline, either minocycline or TG-cycline, which is susceptible, use out of them. So hence, Acinetobacter, to treat Acinetobacter, there is a different therapy than other than whatever we are dealing for other Enterobacteria. That's why whenever we are treating gram-negative resistant organism, we need to know which organism is there, which kind of resistance pattern we can expecting in them. So hence, other than Enterobacter, so what are most commonly we see? E. coli, Klebsiella, this is more common, or Pseudomonas acinetobacter. These four organisms, usually most of the ICUs are burdened with these four organisms. E. coli, Klebsiella, we have Ceftazidime Astronam combination or Astronam avibactam combination. But for the Pseudomonas acinetobacter, this combination will not work. Why? Because as we know, for the Pseudomonas, there will be flux out because efflux pumps are more common, and for the Acinetobacter, intrinsically resistant Astronam is there, so hence this combination will not work. So for this combination, we have to go for our old therapy like polymyxin based therapy, either for polymyxin plus something. But in Pseudomonas, we cannot use tetracyclines, as we seen earlier. Tetracyclines are inherently resistant, so either polymyxin plus whatever susceptible for Pseudomonas, or wait for like Cephalosporins if will come in 6 months, so we can use that. Right now, currently, polymyxin plus whatever susceptible options are there, or we have to see the MICs for Pseudomonas, which is more susceptible. For Acinetobacter, we have polymyxin plus either sulbactam or tetracycline if it is susceptible. So this combination is preferred for Acinetobacter. This is the data which was suggesting for extremely drug resistant Acinetobacter, which is suggesting most sulbactam plus combination. Yeah, so either you can use sulbactam as a backbone or a polymyxin based regimen. Either you poly plus sulbactam or sulbactam plus some minocycline also can be a good option, or sulbactam plus poly can also be a good option. So you can use either poly as a backbone or a sulbactam as a backbone, whatever availability is there as per your availability and whatever MICs you have with you. Now, I would like to focus on one point about colistin. I don't know what kind of susceptibility you are getting, but now colistin we don't mention as susceptible. We have to, as per the recent CLSI and UCAS guideline, we have to mention it as an intermediate. We are not supposed to tell it as sensitive. It is supposed to be intermediate, and because its breakpoint has been reduced, so it is only labeled as an intermediate. We don't label it as a sensitive, so it is labeled as an intermediate. I'll like to go with the case. I'll go fast with this case. There was because I want to focus on one important point about E. coli and Klebsiella. So let's see. There was a case who was AML and he received some chemotherapy. After that, he became a neutropenic. It has developed febrile neutropenia. After febrile neutropenia, we have sent patients blood culture. Blood cultures were flagged positive. And as I told you, okay, as where I was working, we have some molecular diagnostic test. When blood culture blood fact positive, we ordered this molecular test which is known as sepsis flow. So I'll tell you what sepsis flow has told us. Sepsis flow has told us that there is an organism which is Klebsiella pneumonia, and these are the particular therapies are there, like resistance pattern markers are there, resistance marker like CTXM, NDM, and OXA-48. As I told you, okay, as we know, okay, CTXM is a class A ESBL, OXA-48 is a class D carbapenemes, and NDM is carbapenems. So we know that this Klebsiella is carbapenem resistance. Right now, I have to make a therapy. So if it is only CTXM and OXA-48, I would have gone for avibactam based therapy like avibactam ceftazidime, yeah, avibactam aztreonam, because I know that avibactam will inhibit CTXM as well as OXA-48. If it would have been these two combination of enzyme, I would have been happy with ceftazidime avibactam based combination. But as I know, there is NDM, so NDM will destroy ceftazidime. Then who will kill Klebsiella? Nobody will Klebsiella, and Klebsiella kill the patient. So for this, whenever there is NDM is there, I need to give one drug which will not get destroyed by NDM, which was that Astrena. So this and avibactam will take care of CTXM and OXA-48. NDM will not affect avibactam will not affect NDM, NDM will not affect Astrenum, and Astrenum will not get affected by NDM. So Astrenum will kill the Klebsiella. So for this combination, the ideal drug will be ceftazidime, avibactam plus Astrenum. As we know, as per the antibiotic, and then we have started and we have changed patient from meropenem to this combination based on this. So we were waiting for this is the genotypic, this is the molecular test. We have not seen the reports. Let's wait for phenotypic as we were expecting in the phenotype. Now this is the phenotype. I don't know whether you can see clearly, but we can see all the drugs are resistant except colistin, which is an minocycline is intermediate and colistin is intermediate. As I told you, now we, as per CLS and UCAS, we label it as a intermediate, will not sensitive, will not label it as sensitive. So yes, our phenotypic has confirmed it. Okay, it was an carbapenem resistant. This gene has already expressed. Now for this, as I already told you, we need to see for the synergy. Avibactam and Astrenum are working in a synergy because Astrenum avibactam combination is recently available. Previously, it was not available to us. It was only ceftazidime avibactam combination was there, and Astrenum was different. So we used to test for this ceftazidime avibactam and Astrenum in synergy whether these are working or not. But luckily, we don't have to go for all these cumbersome tests because now we have Astrenum avibactam as a combination. So we don't need to do this synergy testing. But as I was in training, it was not there. So we have to do this synergy test. Most of the centers we have to do synergy where this drug is not available, Astrenum avibactam is not available because it has just recently come into the market. So we have to do this synergy, ceftazidime avibactam plus Astrenum. And as we saw, synergy is detected. Means avibactam has taken care of your OXA-48 and CTXM, and NDM is not affecting any one of them, and NDM is not affecting Astrenum, and Astrenum is killing. So what happened? After that, patient was afebrile for few days. Then again, day 6, patient again developed fever and blood pressures become borderline. So we have repetitive blood cultures. And then again, left informed that blood culture is flagged positive. We have done the staining. It shows GNB. Now on this therapy, on ceftazidime avibactam Astrenum, now we have find out on it was Klebsiella. So now we find out that Klebsiella on we were treating, and this patient was on ceftazidime avibactam Astrenum. Now some another GNB is growing. So what are the possibilities? What we were thinking? So as I know, as I told you and as I taught you, Pseudomonas is possible definitely because ceftazidime avibactam Astrenum combination will not work. One possibility was is it Pseudomonas? Second possibility, whether it is Acinetobacter, as we know, avibactam will not act against these oxas, and Astrenum is intrinsically resistant. So it could be possibility of these two. And third possibility is of E. coli. Now, how E. coli can come into the picture, I'll tell you. Why Pseudomonas and why Acinetobacter can come, I have explained it. But what about E. coli? Let's see. We have ordered sepsis flow, and sepsis flow told us that there is E. coli and it's only producing NDM. No other enzyme other than NDM. So what happens with NDM is right now NDM5 is most common in India. With this NDM5, the site of Astrenum binding, which is PBP3. As I told you, we have discussed that there are 4 types of mechanisms. One is enzymatic degradation, one is porin channel mutation, one is flux out, and fourth one is the binding site. So Astrenum's binding site is PBP3. And now we are seeing there is a mutation of PBP3s are there. Whenever there is patient is an E. coli of NDM5, specifically NDM5 and E. coli with NDM, we are finding out this PBP protein binding site or penicillin binding site has been modified or mutated, and because of this, Astrenum will not bind, and hence E. coli is not getting treated with because of this. And now we have enough data, and what we have to confirm with the phenotype also, right? So as we have got phenotype which shows resistant to all. Now how to confirm this synergy is failing or NDM is having PBP3 mutation, Astrenum is working? Again to go for the synergy test. So we have done the synergy test, and synergy has told us that this synergy has failed. It is likely due to PBP3 mutation, which is seen in E. coli. Right now, Dr. Balaji, which is a very renowned microbiologist, he is in CMC Valor. He has published around 20 to 30% of E. coli of carbapenems production NDM producers are having PBP3 mutation. So yes, you have to be very careful when we are dealing with the E. coli for this therapy. So if you have carbapenem resistant Klebsiella, you can go ahead with the therapy of ceftazidime-vectomastronam. There is no issue, or you can go with aztreonam-vectum. There is no issue. But if there is E. coli, you have to be very careful because now NDMs are there. With this NDM, there is PPP3 mutations are there. So we have to be very careful whenever we are dealing with this kind of therapy. So this is data also. I'll tell you. Then we have, and as you know, there's a phenotypically we saw that fosfomycin was sensitive, so we have added fosfomycin, which is, and right now data is coming for carbapenem resistant Klebsiella E. coli. We can use monotherapy of fosfomycin also. So we have added, along with ceftazidime-vectomastronam, we have added fosfomycin, and patient has done very good. So there was data I was telling you. PBP3 mutations are there, and that's how PBP3 mutation is, along with NDM producers are there. Aztreonam is failing because Aztreonam's binding site is get mutated, right? That's what binding site mutation, or where they are binding, if they get mutated at the binding site, they become resistant. So this is coming up for the E. coli. So this is our data I was telling about. See, look at how many percentages are combination percentage, like NDM plus CTXM OXA-48. There are only few percentage there, only NDM and only OXA-48. There are only few percentage in E. coli, and as well as in Klebsiella. There are more of multiple enzymes are there, like they can have NDM plus OXA-48 or CTXM plus NDM or SHV. These all enzymes, there are multiple enzymes. So that's why always you can find multiple enzymes. So this data is because of we have a sepsis flow. If you have a BCID2 panel also, you can have all this data from your particular microbiology lab, or you can ask microbiology lab which kind of enzyme patterns or which kind of resistance patterns are we having, how much percentage of carbapenem resistance are there in our setup. So that's how you can tailor your antibiotic, or when you know the patient is hospitalized, and particular after that, now chances of hospital acquired infections are there, and there is sepsis, or patient is developing bacteremia. So what is our antibiogram suggesting? What is the rate of our carbapenem resistance? What to choose antibiotic? What previously patient was on antibiotic? So as I told you, in this case, what we learned, the patient was already on ceftazidime-vectomastronam, and now he has again developed gram-negative organism. So possibilities could be one, Pseudomonas, because it was not covered, Acinetobacter, and E. coli. So this is how you have to think what are the possibilities of organism and how to tailor our antibiotic therapy for them. Right, and this is our data. As I was telling you, we don't have a single enzyme for antimicrobial resistance. There can be multiple mechanisms for resistance. And as I told you, PBP3, mostly NDM5 is associated with PBP3, and it because of PBP3, aztreonam is getting losing its effect, and other treatment options are either fosfomycin, or again, like we have to go to our polymyxin based regimen, which is what we were using previously. So this is data, and as now other drugs like aminoglycoside of plasmomycin is coming, which might be active against. And as I told you, cephalosporins, which we were thinking for Pseudomonas, it will be also good against PBP3 mutated organism. So cephalosporins, we are looking ahead for cephalosporins for mostly our Pseudomonas and these PBP3 mutated or carbapenem resistant Klebsiella E. coli. So cephalosporins will be a good option for us coming ahead. Yes. So this was the table I was talking about. What if you have these panels, if you know these enzymes are there before your phenotypic pattern is there, because phenotypic pattern will take around 4 days or 5 days after sending your blood culture to know what is sensitive, what is resistant. If you have this pattern, or if you have these enzyme, some method to know, like BCID2 panel are there, or sepsis flow is there. So if sepsis panels are there are some coming panels are there, molecular diagnostic tests are there. If you know this enzyme, so you can tailor your antibiotic at least prior 24 to 48 hours, at least 48 hours minimum you can save for the patient's time. So if you see ESBL enzymes are there, like CTXM, SHV, or TEM, then your drug of choice become carbapenems. Carbapenems are drug of choice, like meropenem, imipenem. It is a very good data. You can use carbapenems and meropenem, imipenem. What about BL-BLI? Yes, avibactam will be most potent BL-BLI against them. So you can use avibactam aztreonam or a ceftazidime-vectum you can use, but we want to spare this combination for our carbapenems production organism, which are producing these carbapenems. We have to preserve this drug for them. So if there is ESBL, carbapenem becomes your drug of choice. If there are AmpCs, as I told you, AmpCs will destroy up to third generation of cephalosporin. They will preserve your carbapenems. So hence carbapenems can be used, or you can use cefepime. As I told you, whenever you see AmpC product producing organism like spice. It has to be light bulb in your mind, MC, spice organism. You have to see spice organism, you have to see MCs, and you have to choose either fourth generation cephalosporin like cephalosporin, or you can choose carbapenems, right? If you have class A and class D like KPC and OXA-48 carbapenemes are there, avibactam combination is best in India because ceftazidime we don't need imipenem, or which is not there in India, imipenem relivectum or meropenem weberbactam we don't need, because we have more predominantly NDM in our. And NDM, we know there is no BLI against NDM, but there is one antibiotic which will not get affected by NDM is your astronome. So astronome becomes our, whenever you see NDM, you can choose astronome as your drug of choice, but first see the which organism. If NDM with Acinetobacter, it will not work because Acinetobacter is inherently resistant to astronome. So you have to see which bug and which enzyme. If you see KPC, OXA-48, NDM, as you most commonly see, OXA-48 KPC is of class A carbapenem, OXA-48 is class D carbapenem, and NDM is class B carbapenem. So avibactam astronome is a good choice against them. So this is the simplified table version which I was talking about all through my lecture. So that's how, if you have a molecular method to know these enzymes, and there are now so many molecular method and molecular tests are available, so we can see all this and we can choose our antibiotic as per this. So what are treatment options we have available for carbapenems? As I told you, old options like polymyxins, which is now we need to use in Acinetobacter or in Pseudomonas, polymyxin based therapy. Fosomycins are there. Ceftazidime avibactam depend on class A enzyme or class D enzyme you are dealing with. Combination with astronome, if class A, class C, or class B, along with class D, if they have class B also, then we have to go for Acinetobactam or ceftazidime-avibactam plus astronome combination. Meropenem, weberbactam, and imipenem, relivectam, as I told you, we don't not no need in India, and they are not available in India. As we are looking further for cephaduricol and cefepime-zidibactam, which will be a good looking option for PBP3 mutated E. coli, as well as our these organism Pseudomonas. We are looking forward for Pseudomonas because we right now we don't have good options for Pseudomonas right now with us. We are looking forward for cefepime-zidibactam for that particular use. And yes, lastly, I would like always think of which bug we are dealing. As I was talking in my lecture, which bug is there, which site we are treating. Now, why site? As I told you, in bacteriemia we should not use TG cycline because it doesn't remain in blood. Site is also important when we are using polymyxin versus colistin. So I would like to emphasize on this point lastly. What is the difference between polymyxin and colistin? There are few differences, as polymyxin, colistin is a prodrug. Colistin methosulfate converted to colistin, and colistin is mainly goes into urine. It doesn't have any good concentration other than urine. So if you are treating non-complicated or uncomplicated UTI, colistin becomes a good choice if you are using colistin. Otherwise, choose polymyxin B. Okay, and colistin you need to, as it's completely renally cleared, more predominantly renally cleared, you have to adjust colistin as per your renal dosing. Polymyxin doesn't require adjustment or renal dosing. So in polymyxin versus colistin, spectrum is same, but which site you are using, it is very important, where site of penetration or their site of, and toxicity wise, polymyxin is slightly, but there is head to head, there is always debate between polymyxin versus colistin, but polymyxin B is slightly less toxic as compared to colistin. So these are two most important, which site you are treating and which whether there is a need to adjust drug or not. So that's why polymyxin, you always remember where you are using. If other than lower urinary tract or other than uncomplicated cystitis, your colistin is for uncomplicated cystitis, colistin is best. Otherwise, use polymyxin B because polymyxin B penetrates other areas very well as compared to colistin, because colistin is completely renally cleared and goes very well concentrated in urine. So hence, uncomplicated cystitis, it's best to use colistin. As I told you, which site we are treating, which resistant mechanism is involved. Now we have molecular tests are available. If you have your good microbiologists around with you, if you have some molecular tests, go ahead with this because it will give you a prior 24 to 48, at least it will give you 48 hours margin to act on. And as we know in sepsis, every hour matters for us to write antibiotic. See, stewardship doesn't mean always you have to escalate or de-escalate. Stewardship always means you have to choose right antibiotic. If a carbapenems production organism is there, then we have to escalate. It also part of stewardship. Stewardship never, or it does not always say ki you have to de-escalate the antibiotic. Stewardship always tells ki right dose, right drug, it has to be there, right? Then, as I told you, get good information from your microlab MICs or other enzymes which are involved from your molecular test. know the BLI spectrum. That's why I focused on what is our BLI spectrum, like avibactam, how much potency is there, tazobactam's potency is what, clavulanic potency is what. That's why BLI spectrum we had to know, and what avibactam covers and what avibactam does not cover. And as I already emphasized on part key, enterobacteria like E. coli, Klebsiella has a different approach than Pseudomonas and Acinetobacter. You have to think about which organism is there. If we are dealing with Pseudomonas, you have to think of different mechanism of resistance. So our approach becomes different, and right dosing strategies we have to know. And if you need any help, get a help of either infectious disease specialist or who is know about this enzyme or these drugs better mechanism, so you can take their help. I would like to end my session, and thank you everyone for listening to me patiently. And now I'd like to go with the Q&A.
Thank you so much, sir, for this interesting topic and an interesting session on it. We have a few questions that have come in during the session.
Right.
I will take them right now. Uh, Dr. Madhav Kulkarni has asked, any therapeutic manipulation to overcome enzymatic resistance like tropulin, metronidazole, etc.?
See, sir, metronidazole has a only spectrum. If you look at metronidazole, it is like only spectrum for gram-negative anaerobe. It doesn't have any activity other than that. So, for other than, see, if you look at this modification therapy, they are coming with like bacteriophage therapy. Like for pan-drug resistant, what we are seeing, it's, I think whatever we are using or the way we are using antibiotic, we are soon landing into, from MDR we have landed into XDR, and soon we are going to land into PDR or pan-drug resistant. For that organism we are coming with this coupling therapy mostly will be with the phage therapy, bacteriophage therapy, or plasmid mediated therapy, what we are seeing in a future. But metronidazole will not help, sir, in any way.
Okay, thank you, sir. We have one more question
Mhm.
by Dr. Pallav Mishra. Role of LORs as a combination drug
Right.
for CRE
Right.
organism.
Right. I got you. LRS also LRS mainly focuses on EDTA, right? They have used EDTA combination, but what LRS problem with LRS is that they have combined with ceftriaxone or they have combined with some beta-lactam. But the problem of amount of EDTA. See, if you look at theoretically, this concept is very good. EDTA is a very good for carbapenem resistant organism. It's a very good because it stands very good. It inhibits. But what amount of EDTA is required is not in the LRS. And my mentor and my two mentors, Dr. Raju Soman and Dr. Parikshit Prayag, has gone through their data thoroughly. And what we have found out ki they have some issues with their testing also. So LRS, what they are saying, EDTA, theoretical, this concept is very good. EDTA is a very good standing point for NDM and specifically for MBLs. It's very good. But the amount it required, the EDTA in vitro and in vivo, it's different. The amount of EDTA is not available, and it's not feasible to give that much amount of EDTA. But theoretical, its concept is very good. I think needs more research. But LRS, I think you should not use LRS because the amount of LRS EDTA in LRS is not adequate. So if you are additional EDTA along with you, you might try, you might get result. That's okay. But in LRS, the amount of EDTA is not adequate, which is required, which is in vitro what they were suggesting. So I think LRS you should not use, sir.
Thank you, sir.
Thank
And
you.
that is all the questions that have come in during the session. If you have any more questions, please share them in the chat box right now. Or you can share it in the comment section later and I can share it with sir
Yeah,
and have them answered. Uh,
definitely. I'll like to solve all the queries and even and thank you so much. I know this topic is slightly boring because of this enzyme, but it's a need to know things are there right now.
so you should see the comment section. There have been very appreciative comments for this.
Thank you.
We
Thank
have
you.
people who haven't found antibiotics and microbio interesting and they have loved the session. So
Yeah, yeah. Thank you.
thank you so much, sir.
Thank you. Thank you.